Good afternoon, everyone. Thank you to Richard and the LSP for asking me to speak today. I'm going to be talking about gastroschisis and work that I was involved in last year. And you'll see as we go through the talk, the relevance of it to all paediatric trainees, not just those who are involved in surgery.
This conference will now be recorded.
Which has been used throughout models of teaching. I'll be able to demonstrate the impact of how small interventions can have a significant impact. And at the end, I'll also talk through a patient journey, which will summarize what we've been discussing. The Lancet did an article which highlighted how many patients globally do not have access to surgical care and anesthesia. It's a striking amount that lack it, and in particular, children are affected by this. They also extrapolated how much investment would be needed for there to be equitable access to surgical care throughout the world. The reason why this is so relevant is by looking at the pediatric mortality data in those under the age of 5. On the left-hand side is the low-income countries, the middle bar, middle income, and on the right, high income. And what you can see by the different color codes is that in the middle and high incomes, mortality from respiratory infections, malaria, diarrhea is going down. But in the low-income countries, although they are also going down, you can see that there is no real change in mortality from congenital anomalies. So why gastroschisis? Looking at global data, in Sub-Saharan Africa, it is now the 5th commonest cause of mortality in the under 5s. Its prevalence is estimated at 1 in 2,000, which then extrapolates to about 16,000 neonates being born with gastroschisis. Why is this relevant? Because sadly at the moment, prior to this study, the mortality was 90 to 100%. So the aims of our study were to undertake an intervention at 7 tertiary centres, 3 in Ghana, 2 in Zambia, Malawi and Tanzania. And the aim was simply to reduce mortality from gastroschisis. In Ghana, we were based in 3 units, Tamale Teaching Hospital in the north, Kumasi to the east, and Accra. Although some of you who know me will realise, unfortunately, I missed Accra. I had tickets to the cricket in June. Zambia, we were based in Arthur Davison Hospital in Ndola and the University Teaching Hospital in Zambia. So the question is, why so much detail?
That's a very good question. We wonder
why so much detail of where we were based. And this is because of the stark differences in the NICU resources. This is a picture of Kamuzu entrance, and that ward is when it is quiet. The NICU resources were very variable depending on the site. They ranged from a basic SCOBU, which occasionally had portable oxygen, through to non-working resuscitators, but as you can see, there was a mosquito net because it's windows and mozzies do get in, to an established unit. The middle picture, the third one along, is in Ghana. And Mozambique had a fully fledged tertiary neonatal unit where they were able to ventilate. Now, in some of the units, they didn't even do CPAP. It was oxygen only. This left-hand picture is actually their surgical unit. They actually tried to separate their surgical from their medical. So, moving on to the methodology. Prior to the study, the PI, Naomi Wright, who is an academic surgical trainee based at King's, had done a pre-intervention data collection, working out what would be required for an interventional care bundle. And the main aim was something that could be sustainable and continued momentum. It is sadly too true that many interventions in lower income countries work very effectively when staff are there, but when they leave, even things like Médecins Sans Frontières, when they leave, things go back to basics. The implementation of the bundle was for a 7-month period from May, and it was 4 weeks at each centre. I was privileged to be able to do 2 at each, and we're carrying on collecting the data until January next year. So what did we need for the study bundle? Well, we needed to have some core components which were standard across all study sites. But there were adaptable components which had to be amended for the local resources and availability. For example, Lusaka Teaching Hospital sadly has a very high antibiotic resistance already, and therefore standard benpen and metronidazole could not be implemented. The core components and the adaptable components were based on data from systematic reviews, qualitative data, and a previous pediatric surgical study involving online survey, which Naomi had undertaken. Now, when we arrive at the centre, we need to have the MDT consensus to actually finalise the details of the bundle. And this was done at the beginning of the 4-week implementation. You would think this was straightforward, but one has to bear in mind this is Africa. There is an awful lot of red tape and bureaucracy, and a lot of time is required to respect the standards necessary to meet. The nurses, heads of department, the superintendents, the matrons, and the first few days are often involved with this. With regards to the bundle, the key issues that had to be taken into account were those that contribute to the high mortality. And sepsis by far is the highest, but hypothermia and dehydration were very common. For some units, the application of a silo was entirely new, whereas in others, they had been using bags that were old saline bags or transfusion bags and ad hoc silos, and some were just doing pure surgery, which significantly led to mortality. We also needed to think about how to manage babies post-silo, and obviously from my point of view personally as a gastroenterologist, the nutritional aspect. Ultimately, we had to develop protocols that were involving a pre-hospital care bundle, then how to apply the silo on arrival, how to manage a child with a silo, bearing in mind that again, some units, this was entirely new, removal of silo, a breastfeeding protocol. Now this you would think would be straightforward, but historically and traditionally, these children were not fed. And the concept of trophic feeding and early breastfeeding was entirely new. And then nutrition. In the UK, in the US and Europe, we don't blink when we think about PN for surgical babies. Most countries in Africa do not have access to PN, or they amend an adult bag, but the majority don't. And a lot of time was used for me to source amino acids and lipids locally. As we go through the talk, how we implemented the protocols, we essentially adapted the patent 4 stage. Time was quite a significant factor, and therefore it was mainly often a 2-stage, but we involved a lot of sim and role play. We did use case-based discussions and problem-based learning. And at the bottom, you can see I've added WhatsApp. Pretty much everyone nowadays we met had a smartphone, and the WhatsApp groups were developed for each site, one for core faculty and one for anyone involved in teaching and training. And the protocols were sent via WhatsApp as a PDF on live discussions whenever a baby was born to optimize their care. It started at the beginning to differentiate between exomphalus, a ruptured exomphalus, and gastroschisis. Here you can clearly see the membrane, the umbilical sac. And while we were there were several cases referred as gastroschisis who in fact were ruptured exomphalus. And we implemented teaching of how to use the remnant of the sac, feed the bowel into it and dress, which is slightly different to the silo. So moving on to the protocols. It may sound basic, but one has to bear in mind that historically, again, these patients were either palliated or arrived in very poor condition. And we went back to basics of when a baby is born with gastroschisis, drying the baby to prevent heat loss, warming the baby, and then what we use here routinely, wrapping it in plastic. Now, cling film is not readily available in many places, but a clean plastic bag, not necessarily see-through, is readily available from most market stalls. And so we implemented a plastic bag, and then the assessment, your basic ABC of neonatal care and resuscitation was reiterated continuously. All babies at delivery with gastroschisis were advised to receive 20 ml per kilo saline bolus. Now, pre-transfer, we needed to think of how we would have the babies arrive at the teaching hospital. And kangaroo mother care is a well-known concept, thankfully, throughout Africa, huge amount of investment. But we had to modify it because obviously babies' intestines meant they couldn't go in the standard position. So we used something that was more like a breastfeeding position. And this involved quite a lot of time because the local staff would need to explain to the mother, because most of these mothers are young, 18 to 20-year-olds. It's their first baby, and antenatal diagnosis is very, very rare. So these are all unexpected, let alone the cultural aspects of whether there has been some juju, whether something has gone terribly wrong, and the guilt that the mother would find. But we did allow breastfeeding, and the reason why this was relevant is because the majority would travel for many hours to get to a university hospital where they could have the silo applied, and it would encourage bonding. We were very fortunate to have very lifelike sim models. Naomi invested a lot of time in getting these correct, and we use these not only to demonstrate the silo application, but each unit received a sim model so that training would continue be an ongoing resource. So you can see on the right that there is a silo applied. The string is essentially a marker to prevent twisting. And here you can see that in gastroschisis, just as in the model, the umbilical cord is separate and to the side. And the real life would be the bowels would be reduced over a period of 5 days. We obviously would demonstrate it live and gently squeeze the bowel back into the model. And we would then also teach how to remove the silo, ensuring that fingers are there to prevent the bowel from coming back up. And finally, we use the umbilical cord to stretch over and actually help close the defect, and then use Tegaderm dressings. So one of these advantages, which was totally novel, was to have a sutureless closure. This has been used quite standard in UK. Post-reduction. So we've taken 5 days to reduce the gastroschisis, and then it was the breastfeeding protocol. Now, with the World Health, breastfeeding is very well recommended. There is no access to artificial nutrition from the enteral side. But again, it was to do with education of a child who's got a gastroschisis that's just been reduced and how you build up feeds. The concept of trophic feeds was very new, even in the teaching hospitals, because traditionally these babies were starved. So we had to remind and educate our colleagues as to the benefits of trophic feeding. And I have to say, this was the same as what I do in the UK when I speak to my surgical colleagues as to why we do trophic feeding. The issues of sepsis, to do with the presence of immunoglobulins, lysozymes, bifidobacteria. The issue of gut hormones. The issue of colonization with favorable bacteria. Now, the other concept that I had to emphasize was the volumes that we were really talking about, to remind all that the amount of colostrum produced in the first 24 hours is 5 to 13, 15 mils per kilo. Tiny, tiny amounts, but hugely beneficial. Apologies, my screen appears to have frozen again. So, the other issue to discuss was the fact that parenteral nutrition is costly and not readily available in the UK. However, data from Mexico had already shown that amino acid preparations were beneficial when combined with dextrose, and that they could be given peripherally. They were much cheaper and required less monitoring. There were also lipid preparations that could also be used. Now, not only was amino acids something to be explored, but even changing fluids from 4 1/5 to dextrose to provide extra calories. Electrolyte testing was not readily available in most units. So what did we explore? Well, I was able to Astamin and selamin are 2 amino acid preparations. And we built it up according to grams per kilo, but what we also had to assess was the actual individual amino acids. And because these, both astamin and selamin, were originally derived for adult burns patients. And when you individually look at the compounds, they are safe in a neonate for about 2 to 3 weeks, but then there would be theoretical risks of hypermethionemia, high lysine, and the difficulty is that we don't know the metabolic effects because A, we may not be able to even test for them, but we recommended that we would only use them for short term. There has been a question with regards to closure of the application. And so what I will do is when I go through a later slide, I will clarify how that is done. The amino acids come as a ready-made preparation. Now, if we use PN or amino acids in the UK, it would be 1 vial per patient to reduce infection risk. But these resources are expensive relatively. 1 bottle would cost about $8, which may not seem a huge amount. But what we did was amend it slightly so that we could have the same patient use the same vial for the length of the time they were in the hospital, and that worked out relatively well. Not to go into too much detail, but just for those who are slightly interested, we not only had to explain how to use something they'd never used before, but in exact details of how to calculate the volumes, how to administer it, and how to manage the child on it. We did a similar process with regards to lipid. Cell lipid, for example, was available in Ghana. It's equivalent to 10% intralipid. It is soy-based, and again was built up. And then there were ongoing discussions about peripheral versus central access, which I'll come to in a moment. Part of the training was not only in relation to the volume we were given, but exactly what calories we could get to. And by changing to 10% dextrose and amino acids, we could reach about 2/3 to 3/4 of the baby's requirement. Using lipids, we were pretty much up to 90%. And this was in stark contrast to prior to this, where babies who were on 4% dextrose and a 1/5 normal saline were on about 1/5 of their requirement. For those interested, this is just the dosage in relation to the calories to work out for the neonates. Part of the ongoing discussion was also how to extrapolate this beyond gastroschisis babies. For example, if the units were willing to invest and do them for all surgical neonates. What about those who have necrotizing enterocolitis? What about the growth retarded babies, the premature babies? And there were many discussions with the nutritionists, the neonatologists, the surgeons, and the pediatricians as to future uses of amino acids and lipid. We did sim training for PICC lines and UVCs. Again, this was based on individual centres. 2 out of the 7 centres were already using UVCs, and this was just a refresher. For others, it was a new concept. Discussions whether or not the risk of using a UVC and no X-ray, which many units were doing, versus no UVC at all, because these babies often had very difficult peripheral access. the PICC line was quite a novel concept, but obviously has its benefits if placed ideally and the length of time it can be used for. And we were able, as part of the study, to not only provide the teaching through the sim, but also provide the PICC lines and the UVCs. So we started off by teaching the faculty, and that would involve small groups, hands-on teaching. We demonstrate, then they demonstrate to us. And we were able to be flexible so that we could do it several times a day or several times a week, so that those who could not attend the initial training could come on another day. Now, you may notice in some of these pictures that there is a bottle of washing up liquid. May I please point out that this is merely for the models. They are quite fragile, and we needed to keep the bowel lubricated well so that it would easily reduce. And by default, we found that the only way to do that was to use washing up liquid. And we were very, very clear when we were demonstrated that this was simply for the model only, and we were not recommending washing a bowel in liquid. Now, when it came to demonstrating the cord, there is a protocol in how to keep the cord moist so that at day 5, when the gastroschisis had reduced, we were able to bring it over. It was to do with using wet gauze surrounding the base. We were advising as part of pre-delivery care to ensure the cord was cut approximately 8 centimeters, and that it was part of the routine 2 to 4 hourly observations that the cord was kept moist. What was really good to demonstrate was once we taught faculty, it was almost the old-fashioned see one, teach one, do one, because we enabled the faculty to then teach to the outreach. And unsurprisingly, it was often the sister in charge who would undertake this. And it was so nice to see all the teams involved. We travelled to several outreaches, and again, extra time, not just for the travel, but to go through all the formalities to ensure that everyone was involved and informed. Sometimes we had a really nice room, and sometimes we were in a little cubbyhole. But what was really nice was the ripple effect. Now, those of you who were into pediatrics a few years ago, this was a real high point of where a hub would then teach a small centre, and then the small centre would go on to teach. And here you can see Sister Nakena, who we had taught, was then teaching her NICU nurses because they couldn't leave, and was also involved heavily from becoming a trainee to a trainer. And this was consistent throughout all the study sites, that the faculty would undertake the training. We just introduced the concept. But my work abroad did not just involve gastroschisis. I had the privilege in Ghana of being fast-tracked as an associate professor. The reason being is Dr. Moomin was the only paediatrician in the region, and got slightly excited that there are now 2 of us. And I obviously was delighted to be involved in ward rounds. This is one group of students, and they were split into 2. So a second group would join us. So you can imagine how complex our ward rounds were. But the interesting thing was how much they valued the teaching, and the fact that several of these students continue to stay involved with complex cases and have been inspired to think of paediatrics as a career, which prior to this they were not too keen on. Now, obviously, there's lots of pathology when we go to many sites in Africa, and the reason I brought this particular case up is not because of the obvious phocomelia, but because this child had a BSD and had classic signs of respiratory distress and heart failure. And what we did was use his signs to use a video, obviously with consent, which the students were then able to replicate, and then give them the idea of recording numerous signs as video apps so that they could then be shared. Africa, if we didn't mention severe acute malnutrition. However, the reason I'm bringing this case up, apart from reminding us of where we are, was my difficulty in understanding why this child with severe acute malnutrition, known as SAM, was still not gaining weight in hospital. And I just spent a little bit of time to try and work out what was going on. So I first learned that mother was from a different region in Ghana and spoke a different language. But thankfully, through all those medical students, one of them was from the same tribe and was able to converse. And I took mum aside, away from the open ward. And it really was a reminder to, no matter where you are, you go back to basics. You remind yourself to take decent history and you communicate. And it turned out that this mother had been advised to give F100, which is the standard formula for malnutrition, and the nutritionists were beautifully recording on a piece of paper every week how much the child was giving. But actually, that was what was recommended and was not what was actually being given. The mother was struggling to feed the child. He was struggling to tolerate it. She was listening to numerous people in the ward who were trying to give their advice. She had also been slightly stigmatized of how she could allow her child to become this unwell. And so equality and diversity issues were pretty relevant even then. And it turned out that all we needed was to get the mother to agree for a nasogastric tube and to actually remind the nurses that just what we expect them to receive should actually be received. What was happening was this child was simply given the volume, and then if it didn't tolerate it, there was no backup. Should we repeat it? Should it be given? Mum also was listening to so many people that she was trying all sorts of different formulas in between. So it was no surprise that the child was still vomiting. And it was just a humble reminder that no matter where you are and whatever the condition, basic history taking, examination, communication, and being aware of individual diversities is really important. Our nurse specialist, Jenny, was very keen to ensure that we also looked at NICU training as an overall. We were able, through a separate charity, to provide neonatally dolls. And they had just started implementing regional equivalent of NLS. And so the models were really useful. And the concept that really was very new to all the units was nesting on the right-hand side. So much time was spent regarding sepsis, hypothermia, hydration, that very little was about positioning, nurturing the environment, because they were very, very noisy NICUs, lots of beeps, lots of alarms, lots of chat. And Jenny was able to get a load of nests donated and do ongoing training with them. And you could see a genuine change in the behaviour of the NICs. Now, it wouldn't be me if I couldn't get my hands on endoscopy. And this was just an example of donated equipment. It had been given to the Arthur Davis Children's Hospital 2 years ago, but the instructions had got lost and it had never been used. And I was thankfully able to put it together again and get it working. And the surgical consultant who had recently transferred there was now able to retrieve, for example, bodies, rather than have a child travel 5 hours or 6 hours to Lusaka, where the only other place for endoscopy was. It wasn't all work, however. It wouldn't be me if I didn't show you a picture of an elephant in Africa. We were very pleased that Monday to Friday full on work, but weekends were our own. But there were challenges. Geography was the major challenge together with transport. Many babies, because of the lack of antenatal diagnosis, were born in either rural healthcare centres or a small district hospital. And how they would be transported was very different depending on the country. There were some ambulances available and some hospital transport, but in order to get hospital transport for a gastroschisis baby, it did involve a lot of red tape. However, we also implemented the idea that it didn't have to be hospital transport. If a family could afford transport publicly, you could still do kangaroo mother care modified under a cloth and actually arrive relatively safely depending on the distance. But when we were doing the outreaches, for example, in Zambia, Naomi travelled over 8 hours just to get to one regional district hospital. So you can imagine how that would be a major challenge. And it was beyond the remit of our study to look at national transport for these countries. And it was left for the individual units to work out through their network, how are they going to improve. Sepsis is still an ongoing issue, even with the best silo application, the best management of fluids. These children often were still succumbing to sepsis. And it's an ongoing issue of ways of reducing this. The other major challenge was essentially the whole culture change of the concept of gastroschisis. As I said, up until then, I would say more than 70% were palliated because they knew that by the time the child got to the hospital, they would be in such a poor state that the child would die anyway. And it was up to the local midwives and the local health staff to actually be able to discuss with the mother, but more importantly, culturally, the mother would then need to speak to family elders, her partner, and that may involve then another half an hour to an hour to get the information across, to know that there was a chance. And that's all we were saying. We were not saying we were going to save every baby with gastroschisis, but we were saying that with some changes in management, we were giving these babies a chance. And this is a classic village. This happens to be Ghana, but this could be Malawi, Zambia, Tanzania. You can see that transport, sepsis are all day-to-day challenges, issues of clean water. And all of these needed to be taken into account. And that is why it was so important for us to try and get our teaching across to the smaller hospitals. Now, I'd like to end on a real positive note, on an individual patient journey. This was baby A. Mother was a young 18-year-old, first baby. Father wasn't around because he had to work, but grandfather was. And this was highly unusual because grandfather was the most supportive person I've seen for a very long time. You can see that we've got a silo applied. The nurse is doing her care. There's a nasogastric tube in situ, cannula in situ. On the right is what a closure really looks like. It's not as neat as it is always implied. Now, these are the observation charts. It's fine and fair enough to say baby needs 2 hourly this, 3 hourly this. But what usually happens in most of these places is they have their documentation is variable. Sometimes it's a scrap of paper that's in a folder. Sometimes it's very well documented notes. But we found that for those where they only wrote in the notes once a day in the morning handover, the best thing was just to write little tables out and stick it on the actual incubator itself. And that works the best way, so that feeds were given at the right time, trophic feeds were given at the right time, the NG tube was aspirated at the right time, and appropriate fluids replaced. So there he is, smiling, sort of, with his abdomen closed, and the delight of being able to breastfeed, and that's Jenny encouraging the mother, with grandfather overlooking. This is him at discharge, and you can see how happy everyone is. And then check him out a few months later. You could hardly tell that he'd had gastroschisis. And then to really round it off, because it was their first survivor, the unit then did a poster presentation to their regional teaching, and that would then encourage more referrals and encouraged the culture change of being able to give these babies a chance. I'd like to end by thanking in particular Naomi Wright, who's our principal investigator and allowed me to take part in her study, Jenny Harris, a neonatal nurse who accompanied us on some of the trips, and Melanie Druitt, who's a surgical nurse specialist, who was able to accompany us for the latter parts. Our funding was from the Wellcome Trust, King's Health Partners, and the Royal College of Surgeons. But most importantly, it wouldn't have been possible without the teams that were involved in all the centres, who were just an incredible group of people to work with. Thanks very much. I'm happy to take questions if there are any. Oops. One of the very sensible questions is, because of the risk of sepsis, do we cover with antibiotics from day one? Absolutely. Depending on the unit, it was either benpen, gentamicin and metronidazole. Now, in most district hospitals, even the teeny health centres, pen and gen were available. And so we tried to stick to that. Metronidazole was a bit more tricky, and you usually would only be added in when they arrived at the hospital. As I mentioned, Lusaka and Tanzania, who were slightly more better resourced, we had to amend their antibiotics. Lusaka needed clindamycin. Another question is, are there guidelines for use in other sub-Saharan settings? So this is not just limited to these 7 centres. These 2 were just the start. Gastroschisis. There's global work from the Ped Surgical Unit. There's something called GITS. It's Global Initiative for Children's Surgery, and they're trying to extend it to other centres, and they plan to implement the same sort of protocol, for example, to 50 centres in Nigeria. How much did we pay the faculty to attend? Well, the faculty that were in the unit we just provided, surprise, surprise, lunch, snacks and nourishment. For those who were travelling, we would pay for their travel expenses, but they didn't have a study leave budget per se, but most of them were happy to have their travel covered. Nasogastric tubes. Nasogastric tubes, I wouldn't use the word readily available, but were available, and that's because mainly from the malnutrition kids, because it's pretty standard. If you're admitted with malnutrition, you'll get an NG tube, and it was more to do with the sizing to make sure the NICUs had them, access, and we didn't have to implement the NG tube, so we didn't try and use, dodgy tubing. We always used an NG tube. I've been asked whether there was any complications through the novel amino acid lipid preparations, and I'm delighted to say no. We so far have been carrying on. The things that have been amended are how we do the Tegaderm dressings, what kind of antibiotics, but the amino acid has been safe. Mexico has shown this, and we haven't had to need it longer than the 2 to 3 weeks. We are planning to do the pre and post data analysis, and that's going to be the remit of Naomi. And I know a very sensible question is to do with female condoms. Now, many countries in Africa have tried to use a female condom, and we have tried to move away from that. The reason being is the actual material of the condom is quite fragile, and you'll often tear and have leaks, which will contribute to sepsis. The spermicide in the female condom actually works rather toxic to the bowel and can cause necrosis, and so it's kind of like burning the bowel. So we have actually very strongly recommended no female condoms. Anything else? I think I've addressed most of the questions. Let me just check if there is anything else. We've got a few minutes to spare. Please feel free to send in any information. And for those who are interested, my email is my name, sandhya.naik@nhs.net. Feel free to directly contact me if you are interested, and I can deal with your queries. And thank you for all the thank yous that are coming through. Dr. Berg, would you like me to stop recording now?
I think, yes, probably can stop recording and just take a question, because I'm in a very windy garden, so you probably can't hear me very well.
Say that again, sorry. While we're waiting for a few questions for those who haven't quite left, there's a question about COVID, and it is true. Through my contacts in Africa, they are seeing a handful of cases. The difficulty is the readily available actual testing. I know the World Health and government said that it is readily available, not quite true. And so because the numbers are so few, apart from South Africa, where it pretty much is working on a UK-based, there is very little at the moment, and we're just watching it carefully. Bear in mind that many places, particularly the smaller hospitals, don't even have oxygen. We're really hopeful that COVID does not take hold of Africa, because I think it would be rather concerning. The average length of stay for a gastroschisis was approximately 3 weeks, and the mothers would either accompany the baby directly, so they would be therefore carrying them in a breastfeeding modified kangaroo position, and so mothers always were able to sort of bond with a baby prior to transfer. So rather than weight gain, by using the amino acids and the lipids, we were able to maintain weight. And that was a significant issue because previous data showed that it was the weight loss that contributed to the morbidity.